Okay, well, welcome back, everyone. Next, we will have our public comment period.
Angela, if you're on, you can get started.
I will go ahead and call our first public commentator, Shay O'Neill. I'm going. Okay, and Shay, you should be unmuted.
Yes, can you hear me?
Yes, we can.
Okay, hi, I'm Shay O'Neill, World Health Network volunteer. Infection control policies urgently need to be updated to incorporate what we've learned about COVID and long COVID. The WHO and CDC have now done their jobs as far as showing clearly that COVID spreads through the air past 6 feet, that it lingers and accumulates inside and remains infectious for hours. They've conveyed that it presents a year-long threat to the public with surges that are the results of actions like increased indoor gatherings without masking, and that is not just seasonal like the flu, but always present and epidemic. They've stated that it's predominantly spread by aerosols and that masks offer protection, with respirator masks like N95s offering superior protection to surgical masks. NIOSH has done their job by testing and certifying respirator masks that filter out aerosols, and manufacturers have made them plentiful and in varieties that offer extra breathability, clear windows, and are MRI safe. I have been doing volunteer advocacy for years now as a disabled high-risk person. I've done my job. I've stayed informed of the growing risk and advocated for myself and others the best I can, but I still do not have safe access to healthcare, and I should. Researchers have shown that hospital-acquired infections account for 40 to 70% of infected healthcare workers and 10 to 40% of infected hospitalized patients. Each reinfection is associated with significantly worse health outcomes and can lead a person into a vulnerable, more at-risk status. We don't have vaccines or sustained immunity that can prevent infection or stop transmission, nor medications that can prevent or cure long COVID, and it's affecting millions and costing billions. However, we can reduce these numbers, slow down viral evolutions, and make vaccines last longer by wearing respirator masks. Researchers have done their jobs. Now it's time for this group to do its job. Only by making respirators like N95s, their equivalents or better, a standard precaution in healthcare settings, do we acknowledge what we have learned about COVID and reduce mixed signals that cause problems. Mixed signals like acknowledging pre-symptomatic and asymptomatic spread, but then having policies where people only mask if they have symptoms. Mixed signals like acknowledging COVID's causing long-term health complications, diseases, and disabilities in millions and across all demographics, but then calling COVID mild or only dangerous to vulnerable people. Mixed signals like acknowledging that COVID can travel long distances through the air past doorways around curtains, but then not requiring all abled building occupants to be masked inside. And finally, there are those that acknowledge all of the above, but then use mask discomfort as an excuse to ignore it all and not mask or require masking in healthcare. It's easier and more ethical to find ways to resolve mask discomfort than to resolve all the consequences of infecting others with COVID and long COVID. Not masking causes significant numbers of people to develop long-term conditions, worsening the quality, durability, and length of lives that would have been better quality, healthier, more energetic, hardier, longer lives had masks simply been worn. We ask that you care about our lives, prioritize our safety, create integrity in healthcare, and update infection control policies to make masks mandatory and standard precaution in healthcare facilities. Thank you.
Thank you, Shay, for your comment. Next commenter.
Our next commentator is Yanir Bar-Yam.
Hi. Can you hear me?
Yes, we can.
So my name is Yanir Bar-Yam. I am professor and president of the New England Complex Systems Institute and a co-founder of the World Health Network. HICPAC is legally required to have 14 members, but only has 11. It lacks airborne transmission experts central to its guidance, the guidance it is writing. Its experts from other domains dismiss airborne scientific evidence in favor of personal opinions. Here are my points enumerated. First, this committee is required to have 14 members. We heard earlier there is a quorum, but with only 11 members absent a statement of its legality, this meeting and the entire effort of work groups do not meet legal requirements. Second, the committee lacks the necessary participation of airborne transmission prevention experts, which is required to decide on guidelines for airborne transmission. Science has advanced. Only a qualified committee should create guidance for COVID-19 and other airborne diseases. Third, some members of this committee are on record ignoring and dismissing scientific evidence on airborne transmission based upon unsupported assumptions, claims, and opinions. While expert opinion may be valuable under some conditions, personal opinions, even of experts and surely of non-experts, cannot dismiss scientific evidence. Fourth, CDC has world experts at NIOSH on many aspects of airborne transmission. Their exclusion from supporting the work group demonstrates absence of good faith by HICPAC. Fifth, this committee has failed to recognize the essential role of policy in society. A person can take risks for themselves. A healthcare provider cannot take undue risks for their patients. Similarly, this committee cannot take undue risks for 300 million people, or even a million, or 10,000, or 100. Enough. Airborne transmission of asymptomatic carriers must be prevented by universal clean air and well-fitting respirators, surveillance testing, extended isolation and quarantine, technology adoption, and we can do it innovation. Thank you.
Thank you, Yanir. We can move on.
Our next commentator is Rosalie Bright.
Hi, can you hear me?
We can hear you. There's just a very long echo after.
Right. Okay, is the echo gone now?
Yes, that sounds much clearer. Thank you.
Of asymptomatic carriers must be prevented by universal clean air and well-fitting respirators, surveillance, isolation, and quarantine.
I don't know what's going on here. I'm hearing Yanir's testimony.
Thank you, Yanir. We can move on. Hi, Rosalie. There may be a delay in your live stream that you may be playing in the background. If you pause that and turn that off, you may be able to hear yourself give a public comment.
Right. Okay, can you hear me now?
Yes.
Hello, can you hear me now?
Yes, we can hear you.
Okay, I see Erica put her thumbs up. Hi, I'm Dr. Rosalie Bright, a doctoral epidemiologist retired from federal service. I remember being trained when I was a little girl to wash my hands with soap before every meal, even if I wasn't going to touch my food with my hands. I remember finding out how quickly one can be thrown from the back seat because your parents slowed the road. I remember learning in Girl Scouts that tiny hot embers can't be trusted to not flare up into a new fire. I remember the seatbelt campaigns to buckle up every time and everywhere, even in one's own neighborhood. I remember when healthcare providers began to be taught to wear gloves for patient encounters, even if the patient seemed well. I remember working as an epidemiologist on medical device safety in the Food and Drug Administration. We worked on medical devices such as gloves that protect both patients and the device users. We also worked on protecting patients and users from devices themselves. A constant principle was that safety features and procedures must be universal and consistent to be effective. My obvious theme is that any safety or protective measure must be practiced consistently and universally. This concept used to be backed and communicated by relevant professional societies and federal agencies, including the CDC. In this century, CDC successfully used it to suppress outbreaks with pandemic potential, including SARS-1 and Ebola. I've been perplexed and horrified by the abandonment of this basic principle for COVID-19. One clear impact of the failure is the continued repeated surges that build on transmission levels that never fall away to zero. One of the settings known to facilitate transmission is healthcare. Half of COVID-19 infectious people are asymptomatic. Healthcare settings include many vulnerable people, ill patients, stressed visitors, and understaffed healthcare providers who are pressured to work even while they themselves are sick. The evidence for special vulnerability is the doubled COVID-19 death rate among patients who caught it in the hospital. A clear lesson from safety research is that layers of protection are crucial because no one layer of protection is 100% effective. For COVID-19 and other airborne illnesses, that means practicing all of the testing, infectious staff staying home, and vaccination. Please revive your professional tradition by applying consistent and universal infection control for airborne pathogens. Side benefits include stopping other respiratory diseases, restoring CDC credibility, and making clear to the wider community that airborne infection controls are important and should also be implemented in other settings. Let's defeat this pandemic and prevent future pandemics. Thank you.
Thank you for your comment, Rosalie. We can move on to the next one.
Our next public commentator is Alida Villatoro. Alida, I've unmuted you a few times. I think you need to, there you go. Thank you.
Hi, can you hear me?
Yes, we can.
Thank you. My name is Alida Villatoro. Before becoming disabled, I studied to become a librarian and received an MSIS. I'm speaking today on my personal experience as a patient who also struggles with long COVID. I have so many wonderful healthcare professionals in my life, but often when I ask them to mask, things can become contentious. It can shift the dynamic from concerned to combative or disinterested in my health issue. The burden of safety is on me, and this leads to not always seeking care when I need it or getting subpar care. So I've also wanted to discuss some research in the Journal of Antimicrobial Stewardship and Healthcare Epidemiology, an article titled Incidence and Outcome of Hospital-Acquired COVID-19 Infections in Secondary and Tertiary Care Hospitals in the Era of COVID-19 Vaccinations. In this study, the authors conclude that hospital-acquired COVID-19 infections in Omicron era were related to high mortality of 11%, especially among patients in medicine wards who also had good vaccination coverage. So the patients who acquired COVID in the hospital, 80% of them were vaccinated. This has also been my experience. I contracted COVID the first time when I was vaccinated 5 times while I was outdoors wearing a KN95 mask. The reason I caught COVID and developed long COVID is because the people around me were no longer taking precautions. And so I no longer had other layers of protection. And this is a risk to me every time that I go to a healthcare setting, including hospitals, to this day. And then I also wanted to discuss a journal article called The Relative Efficacy of Masks and Respirators as Source Control for Viral Aerosol Shedding from People Infected with SARS-CoV-2, a controlled human exhaled breath aerosol experimental study. In this study, they conclude that duckbill masks, which are very cheap and effective, could be given to patients and doctors and be very cost effective in preventing COVID. Thank you so much.
Thank you, Alida, for your comment. We can move on to the next one.
Our next public commentator is Julie Lamb.
Thank you for letting me speak. I am Julie Lam, founder of Mask Together America, a national advocacy group for infectious disease prevention and health equity. As an immunocompromised NIH recovery representative and a long COVID patient, I urge HICPAC members to address the dangers that prevent patients from safely getting healthcare. Immunocompromised people are repeatedly exposed to infection. We are afraid to see our doctors or go to the ER. High-risk patients are foregoing even cancer screening to avoid airborne infections. We need healthcare providers to wear N95s and have good ventilation to ensure our safety. Your guidance must protect those who cannot get vaccinated, including babies. In 2020, my friend Dr. Barry Weber worked at Mount Sinai's ER. PPE shortages and lack of mask use put him at risk. He died along with over 80,000 New Yorkers in this pandemic. Another friend, Chris Terry, had to work while sick. Organ damage and long COVID killed him at age 39. I have spent over 4 years supporting a community of high-risk people who urge me to remind you that your infection control guidance can either move America forward or set us back. Please set the guidance to prevent the next pandemic. Focus not on cost, but on the threat of novel pathogens driven by climate change. Protect us from airborne infections, including COVID, flu, TB, and measles. Prepare for avian flu and the new deadly Mpox, which we know can be airborne. Universal masking, routine testing, sick leave, and ventilation that meets ASTRA standard 241 are essential to prevent transmission. Hospitals should be required to provide workers who are constantly exposed to airborne diseases with N95s, not leaky surgical masks. FDA and NIOSH say surgical masks are not protective enough. You must not suggest a false equivalence. I strongly urge you, don't base your guidelines on harmful vaccine relax strategy for pathogens like SARS-CoV-2. There's no such thing as mild COVID. I can attest, long COVID can follow all infections. I have IgAN. The chronic kidney disease worsened significantly after I was infected by someone who was asymptomatic and vaccinated. After vaccinated myself, COVID triggers a sleep disorder and Sjogren's syndrome. My kidney condition progressed from stage 1 to stage 2. Since 2020, I've led Mask Together America in supporting COVID vaccine rollouts throughout our educational campaigns. But my doctors say I can no longer take the vaccine, which causes severe hematuria and glomerular nephritis. Even though CDC recommends that immunocompromised people double up on vaccines. Please protect those of us who can't get vaccinated. You must strengthen, not weaken, mask guidelines to protect the most vulnerable. Thank you.
Thank you for your comment. We can move on to the next commentator. Thank you.
Our next commentator is Irma Westmoreland. Irma, I think you need to unmute yourself.
My name is Irma Westmoreland. I'm a registered nurse and vice president for National Nurses United, the largest labor union and professional association for registered nurses in the U.S. Given our critical role in infection prevention, nurses' input is essential as you update infection control guidance for healthcare settings. It is a major improvement that you have added NNU's industrial hygienists and other experts to HICPAC's isolation precautions guideline work group and NISNA's health and safety representative to HICPAC. But it is disappointing and frankly concerning that you have omitted an invitation for public written comments for this meeting. The message you are sending to healthcare workers is that you don't care to hear our insights on protecting patients and staff. In healthcare, we face a range of hazards, from workplace violence to ergonomics to infectious diseases. They are all preventable. We only face unsafe conditions when healthcare employers fail to take action to protect us. NNU's 2024 infectious disease survey found that healthcare employers across the country are failing to put in place protections against infectious diseases. Only 1 in 10 nurses report that patients are always screened for respiratory infections. Only 4 in 10 nurses report that patients with respiratory infections are always isolated. Many nurses report insufficient PPE use. For TB and COVID, only 6 in 10 nurses report their facility uses a respirator. HICPAC and the CDC have a choice. You can create guidance that gives healthcare employers flexibility to prioritize profits over robust infection prevention measures. Or you can choose to create strong science-based guidance that directs healthcare employers to take the necessary steps to protect us and our patients. Throughout the COVID-19 pandemic, we have seen clearly what healthcare employers do with flexibility. They lock up PPE, they rip respirators off nurses' faces, they tell us surgical masks are sufficient and deny us access to N95s when we know the science says otherwise. They deny us access to the measures that would protect us and our patients. I urge you to follow the science on aerosol transmission, follow the science on ventilation, respirators, source control, and isolation. Listen to the nurses on the protections our patients need. Thank you.
Thank you, Irma, for your comment. We can move on to the next commentator.
Our next public commentator is Dawn Ford.
Hi, can you hear me?
Yes, we can. Thank you.
Perfect. Thank you. Okay, my name is Dawn Ford. I have no conflict of interest. I want to first start by thanking everybody who's coming to participate in this and try to make rules that make everyone safer. That's really, really important. I want to say thank you for doing that. Now, I can't help but notice, as these meetings are constantly discussed, some of these rules haven't been updated in as long as 20 years. And in the past 20 years, as many of you know, there have been significant jumps in how we interpret and even diagnostic these data points on safety. Now, the biggest one that we're facing that a lot of people are not thinking about, the specific word choice, is we're learning more about the effect on the brain. And through all these rules that are being set up, they're coming from an era where we did not have the diagnostics to properly determine the negative effects that were happening to people's brains. And we can talk about this in a public setting or how it's affecting the public on a larger scale all day. But when we're talking about in a healthcare setting, we're learning that the people we depend on to provide healthcare, to make important medical decisions that can be life or death for somebody. It might just be a day at work for that person, but it is life or death for that patient. And we will all be patients one day. We have to properly understand the damage that is being done to people's brains and how that is going to affect their ability to administer care. Our understanding of the brain has changed. Our ability to do diagnostics on the brain has changed. The CT scans have changed, or MRIs have changed. All these things have advanced, and we have new concepts on how people are affected negatively. And I cannot stress the importance enough that this committee properly take that into their assessment on what needs to be done. I feel like a lot of the discussion that's happening here is still being based on very old science. And the whole point of updating these is putting it in a place where it will look for the next 20 years and the 20 years after that. And these things do need to be updated more often. But I think we can admit that the decisions made here are not trivial. They are important. They will affect people's lives. And I appreciate, for example, that some of the decisions made last year regarding airborne protections are being reassessed by the committee later this year and throughout this year, because science changes that quickly. That's how fast we get to a place where now we have changed our definition of airborne to anything that travels through the air, which is taken droplet theory out to the dumpster, where it will stop putting people at risk. Because we need to understand that in the right conditions, droplets can become aerosol. These things can be transferred this way. And that ultimately harms not only patients, but the medical professionals that we are trusting to administer life-saving care. So I just hope that everybody will think with a clear conscience when we make these new rules and decisions, that we're thinking about their long-term use and how many people they will truly impact. It's easy to see this as just another day, but for everyone it affects, it will be the day. Thank you. Thank you.
Thank you, Don, for your public comment. I would like to move on to our next commentator.
Our next public commentator is Kayla Troitsky.
Hi, can you hear me?
Yes, we can.
Hi, Hi, thank you for having me. My name is Kayla Trowitsky. I have had long COVID for almost 4 years now, from one infection back in 2020. I've also volunteered with the World Health Network as well as COVID Survivors for Change. I'm reaching out to express my deep concern about the current state of infection control and doctors' offices, hospitals, and other healthcare settings. Since the abandonment of universal masking policies, these spaces have become increasingly hazardous, particularly for those of us who are actually trying to avoid COVID and other airborne infectious diseases. The situation has become untenable. It requires immediate and decisive action to protect public health. As we all know, this disease is far from over. While there may be a perception that the worst is behind us, the reality is the virus continues to spread, mutate, and cause harm. Its long-term effects are well documented, with many individuals experiencing chronic health issues such as long COVID, like myself. This condition can be very debilitating and can significantly impact the quality of life. For people who are immunocompromised, have underlying health conditions, elderly, or other conditions that make them high risk for COVID, the stakes are even higher. These individuals rely on healthcare environments to be safe, controlled spaces. They should be able to receive the necessary treatment without the added risk of exposure to infectious diseases. Unfortunately, without universal masking and stringent infection control measures, these environments are no longer the safe havens they once were or should be. The current state of affairs has forced patients into a difficult and unacceptable dilemma to either risk exposure to a potentially life-altering virus by attending medical appointments, or they avoid seeking necessary healthcare altogether, which can lead to serious and sometimes irreversible consequences. No one should have to make such a choice, especially in settings designed to promote healthcare and healing. To address these concerns, I am calling for the immediate reinstatement of universal N95 masking in all healthcare settings. Simple cloth masks and surgical masks are insufficient to prevent the spread of airborne pathogens, particularly in environments where vulnerable individuals are concentrated. N95 respirators are proven to be far more effective at filtering out airborne particles, including viruses, and should be the standard equipment for all healthcare personnel and patients alike. In addition to universal masking, I urge the implementation of comprehensive infection control protocols that include HEPA filtration and UVC disinfection. HEPA filters are capable of trapping airborne particles such as viruses and bacteria and can significantly reduce the concentration of pathogens in the air. When used in conjunction with proper ventilation, HEPA filters can greatly improve indoor air quality and reduce the risk of transmission. Protecting patients should always be a top priority in healthcare settings. Thank you for your attention to this urgent matter, and I hope that you'll prioritize health and safety of patients.
Thank you, Kayla, for your public comment. We appreciate it. We can move on to our next commentator.
Our next commentator is Noah Strauss.
Would it be possible for us to turn our video on? We use American Sign Language.
Let me check.
Yes, it's fine.
Is that okay? Okay.
It's okay.
Yeah, it's very important that it be accessible.
Yes, 1 second. Okay, you should have video access now. You should be able to see the little video icon that you can turn on your menu.
Okay, are you able to see us?
No, we are not. I am
able to see you.
Yep.
I am able to see you.
Perfect.
We see you.
Hi, so we deeply need universal masking requirements with fit tested N95s, respirators at all times in medical institutions, hospitals, nursing homes, congregate care, and otherwise at all times to dramatically decrease hospital-acquired infections of both staff and patients. The current draft guidance, as we last saw it, has systematically weakened the numerous recommendations in the guise of standardized terminology across the document and through use of the word soiled over contaminated. To this first point, in patient placement number 5, anytime room sharing occurs, precautions need to be in place to limit potential for cross-contamination. This was downgraded to should be in place. This changes a must-do requirement to a nice have type requirement. Similarly, under routine air precautions, a mask is worn by healthcare professionals on entry into a room was downgraded to healthcare professionals should use a mask on entry into a room. The original is a requirement, while the revised sentence is a suggestion. Furthermore, a soiled mask is one that is visibly dirty, which makes the burden requirement for changing a mask, as opposed to being forced to reuse a mask or getting a replacement mask, a higher threshold to meet. Employers would easily misuse this criterion to then ask personnel, well, is your mask soiled? No, then you're fine to continue wearing it, when the mask would then be a continued source of contamination and possible infectious transmission to both healthcare providers and to the patients that they're caring for. Again, a well-fitted N95 respirator needs to be explicitly defined, as opposed to the incredibly vaguely written source control that replaced areas where masks were originally written. The most egregious example of weakening the guidelines is saying one should use PPE when someone is visibly sick or symptomatic. This ignores asymptomatic presentation, which still results in infection, and completely disregards a patient's exposure history. Every patient should be treated as possibly infectious. This is the only way we can reduce nosocomial hospital-acquired infections like SARS-CoV-2. It's the only way to make hospitals safe and to put people, making it safe for people at the highest levels of risk, like people with tracheostomies. Thank you.
Thank you so much, Noah, for your comment. We can move on to our next commentator. Thank you.
Our next commentator is Sefer Almasi.
Hi, can you hear me?
Yeah, perfect. Thank you. We can hear you.
Thank you. I'm Cypher Almasi, a member of the public. I am deeply sad and very angry that the CDC and HICPAC failed and continues failing to provide the guidance needed to make healthcare settings safe for all who seek or provide healthcare. This failure affects me personally. Pre-pandemic, I regularly attended my routine appointments with healthcare providers, but now those providers do not acknowledge that COVID-19 transmits through aerosols. Where are the COVID-19 policy documents to inform me about the protections in each healthcare facility? Why are healthcare representatives confused when I call them with questions about COVID-19 safety? If I seek care and I share air with a person who is sick with COVID, how can I expect to safely receive care? In the absence of information about safety, I cannot assume that I'm safe. So I am still avoiding healthcare as much as possible. When I did seek care for a COVID-19 booster and flu shot last year, it took me 34 phone calls and 4 hours of waiting on hold or pleading to find a provider who would wear an N95 respirator during my appointment. My experience makes me concerned for people with urgent needs who cannot choose to forego healthcare when there is no infection control for aerosol transmission. In the last year, my relative suddenly acquired heart and respiratory conditions. Whether this is the result of cumulative damage from repeat COVID-19 infections or something else, I cannot say. Regardless, if my relatives feel unwell, they must go to the hospital for life-saving care. But what's protecting them from a COVID-19 infection that could worsen their conditions? Lately, I think a lot about my friend Abby. She's a wonderful, kind person. She's also dealing with chronic health conditions that require long-term care in a hospital. And she's got a heightened risk for developing long COVID. So every time Abby encounters a person with an N95 respirator, or if she needs to remove her N95 to receive care, she's in danger of getting sicker because of COVID-19. My friend's situation is harrowing and unjust. And you, HICPAC members, could write infection control guidelines that could help keep Abby safe. But you've done nothing of consequence. Why do you refuse to protect people from respiratory pathogens? I can't believe it's up to the public to educate you, the experts, but here's 5 things you can do. 1, fully recognize aerosol transmission of SARS-CoV-2 and other respiratory pathogens. 2, write guidelines that use multiple control measures to prevent aerosol transmission. 3, declare that N95 respirators are the minimum and essential protection for staff and patients. 4, incorporate elastomeric and powered air purifying respirators into any updated guidance. 5, be clear and explicit on the precautions that are needed in situations where infectious pathogens are present or may be present. Don't adopt a crisis standards approach. To conclude my comment, members of HICPAC, understand that you abandoned healthcare staff and patients to endless COVID in healthcare settings. Fix this. Do better. I yield my time.
Thank you, Cypher, for your comment. We can move on to the next commentator. Thank you.
Our next commentator is Paula Marks. All right. We'll move on to the next. Our next commentator is Andrea Taglieri. Andrea,
can you hear me?
Yes, we can hear you now. Thank you.
Good afternoon. Thank you so much for this opportunity to speak. Ditto to what everyone else has said before me. That was excellent. I am a disabled therapist, former avid hiker, former avid pickleballer, former water aerobics fanatic, former avid adventurer, and most of all, I'm a former lover of life who is now trying to deal with a stolen life. I have a dysregulated immune system and on immunosuppressants as millions and millions of other Americans. So I wanted to ask to please establish universal masking in healthcare across all settings. Many aerosol transmitted pathogens are transmissible without symptoms and without any predictable seasonality, especially COVID, as we've seen. Diagnosis and isolation also can be delayed, which can lead to exposures that could have been prevented by universal masking. I really feel that we need to ensure robust protection from infectious diseases in healthcare. We need to follow the science. Trying to obtain healthcare should not make us sicker, especially with the knowledge of a rampant, possibly lifelong, severely disabling multi-system illness. Speaking personally, I truly lost my life. It was stolen. I was living my best life, and I ended up unable to speak, unable to tolerate light or sound, unable to feed myself. I'm very lucky I'm able to do that. And I was so excited when I moved back to the East Coast and got to the long COVID clinic. And I was devastated and pretty scared because of what I had been through. It was terrifying to be in silence and darkness 24/7. Not even being able to tolerate touch following, with this long COVID, with the myalgic encephalomyelitis presentation. I got to the long COVID clinic. No one was masking. My life was stolen. And there's such great threat and great fear. These people, I'm in a small room. They're taking vitals up close to my face. Horrific. And if I say, I'm scared, can you please mask? My life was stolen. I get shamed. And it's just, if there was universal masking, that wouldn't be an issue. I just would like to be protected and that the gains I've made would not be lost again. Please help protect me and millions like me. Thank you so much for your consideration. I appreciate it.
Thank you, Andrea, for your comment. We appreciate it. And we will move on to the next commentator. Thank you.
Our next commentator is Linda Green.
I'm Dr. Linda Green, a physician board certified in internal medicine and medical oncology, who has been volunteering with PanEnded, an organization of people with disabilities focused on COVID-19 and disability justice. PanEnded has approached the CDC and local health officials to reinstate mask requirements in healthcare settings. Today, with the surge in COVID infections, it is now clear that COVID is not seasonal but present year-round. Mask requirements provide infection control and ensure that high-risk people have equal access to healthcare spaces. Masks protect patients as well as hospital staff. In particular, high-quality masks are most protective. N95 and KN95 masks should be the standard used by healthcare workers, nurses, and physicians. Patients should also wear them if possible. Visitors to hospitals, nursing homes, and clinics should be provided with masks as well. I have been pleased to see this latter step present in VA hospitals and the Cancer Hospital MD Anderson. It is a step in the right direction that oncology, dialysis, transplant, and ER units have more often required this level of protection, although compliance is spotty and accountability is limited. But this effort at selective protection is flawed. Protection for all patients in a consistent fashion is more likely to succeed in limiting hospital-acquired infections with COVID and paves the way for protection from other airborne infections such as flu, Mpox, RSV, and possibly bird flu. Some of you may not realize how easy it is to misclassify a patient as immunocompetent, to miss aspects of a patient's history, to have patients unaware that they are high risk, and to focus only on the acute illness with a goal to rapid discharge in our hospitals today. N95 masks make these situations less dangerous to patients and staff. Changing the culture to masking for healthcare workers and institutions is as important today as years-long campaigns for hand washing have been. Some favor flexibility in the use of masks, lower quality or more comfortable masks, pegging them to community data, and so forth. However, protection is limited and often abandoned altogether when these compromises enter into policy. The argument that vaccinations have made this less important is also flawed, as uptake on boosters is too low for the system to rely on one strategy. And alone, vaccinations cannot resolve issues with COVID-19. Researching mask design and respirator use may be worth considering. Listing COVID as a hospital-acquired infection can help in data gathering. Establishing standards can give the Joint Commission a role to play in compliance and accountability. Testing patients on admission to hospitals and clinics can help busy physicians and alert departments where isolation may not yet be routine, such as cardiology testing labs and radiology. Isolation guidelines for healthcare workers need to return to having someone with COVID return to work only after negative tests. Paid sick leave for these workers and provisions of tests is necessary for safety. In all of these interventions to prevent acute infections and decrease risk of long COVID, the issue underlying much of this is cost. We can all join to demand that the current healthcare system pay for what is needed and reject compromises. Thank you.
I want to thank you for your comment, Linda. And we can move on to the next commentator.
Our next commentator is Daniel Besanov.
Good afternoon.
Hello.
Hello.
Yes, we can hear you. Thank you.
Hello, my name is Daniel Besanov, a member of the public, and I'm here to address the urgent need for stronger COVID-19 prevention measures in healthcare settings, specifically the use of N95 respirators. COVID-19 is airborne and highly contagious. We know from multiple studies that N95 respirators provide significantly better protection than surgical masks. And two-way protection is far better than one-way. Yet, the CDC's latest guidance prioritizes hand washing, which does not address the primary mode of transmission, airborne particles. The CDC's reluctance to recommend N95 respirators seem to stem from political pressure rather than the science-based evidence that should guide your decisions. Although masking is highly polarized, politicizing public health will only lead to more death and disease. We cannot rely solely on vaccines to protect us, as just a quarter of US adults received the updated COVID-19 vaccine, and less than half of those ages 65 and older. And the effectiveness of the vaccine wanes significantly after 4 to 6 months. Transmission-based precautions should apply universally in healthcare settings because about half of COVID spread is asymptomatic. And long COVID is a risk for everyone, not just the vulnerable. With 18 million having had long COVID, including children and healthy people, and repeated reinfection increases the risk of long COVID. I want to share a personal story. My grandmother, whose daughter refused to vaccinate her, was hospitalized with COVID earlier this year and spent a month in critical care before she passed away. This was her third COVID infection in a healthcare setting, and no one around her wore N95 masks. She had no control over her protection, and it ultimately cost her life. This is not just about the elderly. It's about the millions of others who are equally vulnerable. Hospital-acquired COVID is unacceptable when we have such a cheap and effective preventative measure as an N95 respirator. The power dynamics between patients and healthcare providers make it almost impossible for patients to request that staff wear masks. When I asked my primary care doctor to wear an N95 respirator, she refused, saying that it goes against CDC guidance. I am afraid to push the issue further, fearing that I might be dropped as a patient. No patient should have to repeatedly request healthcare providers to wear N95 respirators every time they visit their doctor. I implore the CDC to issue clear and unequivocal guidelines for the use of N95 respirators in healthcare settings. Two-way protection is far better than one-way, and nobody should have to ask their doctor to protect them. Thank you for your time and consideration.
Thank you, Daniel, for your public comment. It's very much appreciated. Daniel is the last public commentator that we have today. I would like to thank all commentators for giving us your time so that we could hear your voice.